and 128 among the year.
Hi everybody, we'll continue the thyroid chapter. Today we'll be discussing thyroid carcinoma, malignancies of thyroid. This is a revision of what you read in pathology. We'll just revise quickly with a clinical scenario. Now, thyroid carcinoma is the commonest endocrine cancer. The female to male ratio again 3:1, and it is the fifth common carcinoma in women. Basing on the age, it is more lethal after 40 years, but it is more aggressive in men. Though it is uncommon in men, but when it occurs, thyroid carcinoma is more aggressive when compared to the females. What are the risk factors? Again, revisiting your pathology, there are one is genetic. The classical example of thyroid cancer running in the families is medullary thyroid carcinoma. Second is irradiation or exposure to X-rays. When it occurs in younger age, it may lead to thyroid cancer at a later age. And this irradiation may be therapeutic or accident. Therapeutic, the classic example is Hodgkin's disease in the younger age when treated by X-rays may predispose to thyroid cancer. Accidental, well, accidents at the nuclear power plants, nuclear establishments. We have a number of these. Classically, 3 Mile Island, Pennsylvania, USA, in March 28, 1979. There is a nuclear reactor dysfunction, leakage of radiation. And again, Chernobyl disaster, USSR, former USSR. April 26, 1986, there is a big disaster. And of recent in Japan, March 11, 2011, there is again another nuclear reactor explosion, releasing high amounts of irradiation into the atmosphere. Classification of thyroid neoplasms, we can classify them into benign and malignant. Benign is follicular adenoma, and there is no entity like papillary adenoma. Papillary adenomas, even if they are well encapsulated, should be regarded as malignant. We have only one entity, that is follicular adenoma. Coming to the malignancy, we have primary, secondary. Primary from follicular epithelium. We have differentiated and poorly differentiated. Under differentiated category, we have follicular carcinoma, papillary carcinoma. Under poorly differentiated follicular epithelium, anaplastic carcinoma develops. From parafollicular or C cells, they predispose to medullary carcinoma. And this parafollicular or C cells, we have already discussed in embryology that they take a common origin from the neural crest. They give rise to medullary carcinoma. From lymphoid cells, we have lymphoma. Secondary carcinomas, they are either metastatic or local infiltration, metastatic kidney or breast. Rarely produces metastasis in the thyroid. Local infiltration by squamous cell carcinoma of the upper aerodigestive tract. But needless to say, these secondaries causes a grave prognosis. The incidence coming to papillary carcinoma is the most common carcinoma, 80%, followed by follicular carcinoma accounting for about 10%. Poorly differentiated and anaplastic carcinoma is 5%, third. Medullary carcinoma around 2.5%, and lymphoma accounts for 2.5% of all thyroid cancers. Clinical features, how this thyroid carcinoma present. It presents as enlargement of the thyroid gland. This is the commonest. maybe single nodule enlarging, sometimes associated with cervical lymph nodes, palpable cervical lymph nodes, especially seen in papillary carcinoma, medullary carcinoma, and rarely in follicular carcinoma. Or sometimes present as a paralysis of the recurrent laryngeal nerve, change in the voice. Rarely, they may present with bony metastasis. And the thyroid is one of the favorite carcinomas metastatizing to bone. And they are highly vascular. We have seen one case while doing on a night duty in KGC sometime back. An elderly man presented with the inability to use right upper limb and the right lower. So the medicine people diagnosed it as right hemiplegia and they admitted. He had two swellings in the shoulder region and the hip region. The duty physician thought they are abscess. He wants me to have a look at those abscess. This all happened at night, emergency, in the emergency duty. When I saw that, they are pulsatile. Oh my God. They are not abscess, they are secondaries. And you look at the neck region, there is a thyroid swelling. But the patient is not worried about thyroid swelling. He says it is present for the last 10 years. A rare presentation like bony metastasis, pulsatile. Why they are pulsatile? There is hyperdynamic circulation and they are highly vascular. Anaplastic carcinoma may present as a very hot, irregular nodule infiltrating into the local tissues like trachea and local muscles. And sometimes pain may be referred to the ear. This is called atalasia, referred pain. When somebody presents with a thyroid nodule, what we do is initial workup after a thorough clinic history and clinical examination. We'll take FNA with ultrasound. Rarely, core needle or incisional biopsy may be required. Coming back, ultrasound now plays a very crucial role to minimize the negative reports. The fine needle aspiration cytology or fine needle aspiration biology is always combined with ultrasound. Very rarely, they may take a frozen section biopsy. And again, to assess the thyroid functional status, we'll go for thyroid profile. Thyroid profile. Sometimes X-ray may be taken for a neck or chest and a CT. Fine needle aspiration cytology or FNA as they call it in United States. You are fresh from pathology, you know the limitations, disadvantages, drawbacks of FNAC. 15 to 40% of follicular neoplasms may be malignant. Well, if you subject a thyroid nodule to FNAC, the pathologist may give report as follicular neoplasm. He won't commit whether it is adenoma or malignant. For the simple reason, FNAC cannot differentiate between an adenoma and carcinoma. The cause, capsular, pericapsular, or perivascular invasion cannot be made out by FNAC. Always the report is follicular neoplasm. Based on the other factors, we will decide what line of treatment we are going to give. And papillary thyroid carcinoma, sometimes you will get as incidental. That is, you operate for some other thyroid condition. The specimen may show a microcarcinoma. Less than 1 centimeter diameter, they are called microcarcinoma. They may never progress to frank invasive carcinoma. This is an incidental finding. That's why it is called incidental. Recently, In this institute only, we have operated one papillary thyroid carcinoma with microcarcinoma less than 1 centimeters. That is diagnosed ultrasonographically and confirmed by FNAC. Physically, clinically, the patient doesn't have any symptoms suggesting a thyroid cancer. Now, ultrasound is now after waxing and waning, sometimes they say ultrasound is essential, sometimes they say it doesn't give much information. Now, it is settled, the matter is settled that ultrasound is one of the fundamental investigative choices in thyroid disorders. It tells us about hypoechogenicity, microcalcification, irregular borders, infiltrating margin or around smooth margin, increased internal vascular. All these things point out to a highly suggestive diagnosis of malignancy on ultrasound of the thyroid. Again, to repeat, hypoechogenicity, microcalcification, irregular borders when compared to smooth borders, infiltrative margin, or increased internal vascular. Any one of these conditions may predetermines that this can be a thyroid carcinoma. Again, you have to confirm by either a histological or most commonly by cytological. This is incidental of what we are discussing. It is increased because we have high quality imaging. Now we have good quality ultrasound machines, we can pick up the lesion. But clinically unsuspected, impalpable. Clinically, the patient doesn't come with there is a swelling or enlargement of thyroid. It is unsuspected, impalpable. It is like, it's not like a pandemic like COVID, it become epidemic because it produces needless anxiety. And most often it is managed expectantly. We have already seen that most of these incidental lymphomas may never progress to frank invasive carcinoma in the lifetime. But you have to draw a line where it is physiological, where it is pathological. These nodules, simply finding a nodule in the thyroid gland on ultrasound doesn't call for a panicky reaction. If you know where to draw a line, it's okay. These are major differences between papillary and follicular. We have seen it is a differentiated carcinoma, most common, we have already seen. If you take male incidence, more number of males are get the follicular carcinoma, 35%. If you take lymph nodal metastasis, 35% in papillary, that is more lymph nodes when you compare with around 13% in follicular. But blood vessel invasion, this is 60% in follicular carcinoma, likely to produce multiple bony metastasis, as we have seen in an unusual presentation of a case. Recurrence rate again 29%. Even if you operate successfully, the follicular carcinoma may recur in almost 30%. Mortality rate you can see almost double. This all means though follicular carcinoma is rare, the mortality is high in the follicular carcinoma when compared with the papillary carcinoma. And again we see when the carcinoma recurs, there may be recurrent metastasis in 75% of cases when you compare with 45% in papillary carcinoma. And the nodal metastasis less, but this is offset by the presence of distant hematogenesis threat. Again, local recurrence less, but still, these two factors are offset by this. 75% is too much. When you say lymph nodal, only 34 and local recurrence 20 in a case of papillary carcinoma of thyroid. When you see the distinct metastasis, we have just seen that it is 75% in papillary carcinoma. If you see lungs, it goes to 49% in lungs. That means 50% have lung metastasis and bones 25%, both lungs and bones 15%, and followed by central nervous system. These are the incidents of metastasis in a case of thyroid carcinoma. Now, when a patient comes, basically it is imperative to examine. Here one case recently, not in this college, some other college, we have seen that patient 60 years comes with a cataract in the right eye. They have operated. They have implanted the lens or intraocular lens or artificial lens. But unfortunately, what they have missed is there is a clearly visible thyroid nodule with metastasis in the patient. These they have not observed, nor they referred to any second opinion like surgery. They are not referred. They are concentrating only on that. After the surgery, she was discharged. She went to home, but complaining of continuous cough. Then she consulted a private nursing home doctor, where he has seen the thyroid nodule. See, this is the thyroid nodule, and this is the lymph. Clear. Any first-year clinical student can make it out. See the visibly engorged vein. This is the lymph node, and this is the thyroid nodule. This is the thyroid nodule, and we have a lymph node here. Another lymph node. How they miss? She went to another doctor because of persistent cough. He observed. Then what? See, this is a lymph node, unmistakable. Here you can clearly see this one and a big lymph node, skin, platysma, elevated cells. How they miss that? When he has taken a X-ray test, there is a pleural effusion. That means there is lung metastasis. That's why she is having a persistent cough. Then he rang me up and said, "What are you doing? You have missed the bus." I said, "No, we are doing our best, but this proves otherwise. This patient requires treatment first for this condition. Then the cataract surgery." Again, coming to bony metastasis, thyroid is one of the favorite primaries which produces mets in the bone, mostly axial skeleton or in the flat bones. This patient, you see one nodule here, and you see multiple metastasis. See, this is a close-up. So much metastasis, and these are all functional vascular pulsatile. If you keep your hand on this, they are pulsatile. They are not dull and dumb. They are pulsatile. These, see the enlarged vasculature, veins. All these are not named vessels. Another lady with thyroid nodule, there is one bony metastasis here, second here is with all this. This is clinically suggestive of most probably a follicular carcinoma. Follicular carcinoma of thyroid producing metastasis. We know that follicular carcinoma produces vascular invasion most likely and produces multiple bony metastasis. Whereas papillary carcinoma likely to produce more lymphnodal metastasis. Here, multiple bony metastasis. That is the sign of papillary carcinoma, follicular carcinoma. Another case. Typical bony metastasis produced by follicular carcinoma of thyroid. Coming to the medullary thyroid carcinoma, it arises from the parafollicular or C cells which takes a common origin from neural crust. And there are some other structures which take origin from neural crust, but they migrate to the specific place. You know that. And these tumors characteristically show amyloid stroma. And there is increased CGA, increased calcium. MTC, medullary thyroid carcinoma, may be sporadic, but familial in 10 to 20% of cases. It is a part of the MEN 2A and 2B, multiple endocrine neoplasia 2A and 2B. And again, MTC, 50 to 60% of lymph nodes may be enlarged at the time of presentation. In thyroid carcinoma, one is papillary, second is medullary thyroid carcinoma. We have lymph nodal metastasis. Papillary carcinoma, it may be up to 80%. That is, in 80% of cases, at the time of presentation, we have clinically palpable lymph nodal metastasis. That comes to 50 to 60% in a case of medullary thyroid carcinoma. And they are not TSH dependent because they originate from the parafollicular or C cells. They do not take up I131. This is important therapeutic implication. When they do not take up means radioactive iodine cannot be used for the treatment of medullary thyroid cancer. That is the implication. And this is the one condition where we can do prophylactic surgery in the infancy, maybe 1 year, 2nd year, when there are RET gene mutations or increased calcitonin, either by basal or you can stimulate by calcium or pentavalent. And if increased calcitonin is present, RET gene mutations are present, that infant can be offered prophylactic surgery 1 or 2 years after the birth to prevent occurrence of medullary thyroid cancer. This is the one classical example where surgery prevents the development of subsequent cancer. A prophylactic surgery aim is to prevent the development of cancer subsequently. Coming to the anaplastic carcinoma, we have seen 5% the incidence, commonly elderly age. This is one of the most aggressive cancers that can occur in human beings. Entire body, one of the most aggressive, presenting as a hard or irregular nodule, infiltrating, locally infiltrating trachea, surrounding muscles, skin, platysma may be infiltrating at the time of presentation. Most of the times it is locally advanced. Rapid growth and a metastasis commonly occurs. There is a poor prognosis, and whatever you do, surgery, if possible, radiotherapy, plus or minus chemotherapy. But ultimately, this is the result. If the grave prognosis, they don't live more than 6 months. After the diagnosis, this is the Western standards or Western statistics. Now, coming to the treatment of thyroid cancer, we have surgery, radioiodine, thyroxine, and chemotherapy. 4 options are available. Surgery, total thyroidectomy you have to do, plus or minus lymph nodal dissection based on the lymph nodal status. In the case of medullary thyroid cancer, this total thyroidectomy is common for everything. Total thyroidectomy plus central or bilateral cervical lymph node dissection, again basing on the individual case presentation. In a case of anaplastic carcinoma, surgery, if possible, most of the times you will not be able to do surgery because it is locally infiltrating, it is too advanced at the time of presentation. Only we can do isthmusectomy to relieve pressure on the thyroid or trachea. That's all we can do, maximum if it is possible. So basically you give radiotherapy plus or minus chemotherapy, but prognosis is universally poor. What are additional measures? After surgery, we'll give thyroxine, levothyroxine, half-life around 8 days. We'll give. The cause, why you give this? Most of these differentiated thyroid cancers are TSH dependent. Okay. Our target is to make this TSH level less than 0.1 these units. We have to, this is our aim, target. We'll give 150 to 200 micrograms of L-thyroxine to suppress TSH so that the tumor will be suppressed. That is the idea. Then coming to radioiodine, I131, when we use is when there are unresectable tumors, local recurrence after surgery, metastasis are present, high risk patient, male patient, engaged or after 40, all these are high risk patients. And there is increased thyroglobulin after surgery. Because after surgery it should be 0. If you have increased thyroglobulin levels on a serial measurement, radioiodine is indicated. Again, unresectable cases, local recurrence, metastasis anywhere in the body, high-risk patients, and increased thyroglobulin levels in a serial measurement after surgery is indication for giving radioactive iodine I131 will give. Now, surgery is done. We have discussed post-operative we have discussed the additional measures also. Now coming to the post-operative complication, what complication can occur during or after surgery? The surgery of thyroid involves a number of critical, contiguous and compact structures in a small area of the neck. Mechanical excision of a thyroid nodule is not a surgical tour de force. When you are doing a thyroid surgery, you are supposed to demonstrate anatomic relationships and key structures of the neck. That is the hallmark of a competent surgeon. Anybody can do a thyroid surgery. That is not important. Is a competent surgeon, what he is expected to do, he should be able to demonstrate anatomic relationships and key structures, which is the hallmark of a good surgeon. Now, first is hemorrhage. Hemorrhage may occur. If you see this is subplatysmal. Under the platysma, hemorrhage occurring, no problem. This is the strap muscles and the deep fascia. Underneath, we have the hematoma. Now, this hematoma, this side is bounded by unyielding or unstretchable deep fascia. Okay, so there is bleeding occurring. Then this will compress the trachea. Some structure must be sacrificed to accommodate this hematoma. So it produces tracheal compression. This is esophagus. This is the vertebra. This is the major vessels, carotid vessels, and internal jugular vein. Okay, there is hemorrhage. Subplatysmal, not a problem, but this is an emergency. It is a deep tension hematoma. Now it is compressing the trachea. There is a respiratory problem and urgent decompression is required. This is the one condition where in the ward itself, you open the skin, subcutaneous tissue, and also the sutures binding the deep fascia and the strap muscles so that the tension is relieved, the tracheal compression is abolished, and take the patient to the theater, find the blood vessel and line it. This you don't wait till the patient is shifted to theater. It may be too late. it requires urgent decompression. When you diagnose this, it requires urgent decompression. Second is respiratory obstruction, largely due to collapse, thinking of trachea. But why there is a tracheal collapse or thinking? That is, in a long-standing cases, there may be tracheal collapse and thinking, coupled with laryngeal edema. The cause for laryngeal edema is again tension. How this vicious cycle is initiated? Observe here. Laryngeal edema precipitated by tension hematoma will result in the collapse or thinking. All these factors combine to form respiratory obstruction. Trauma contributes to contributing factors, and nerve paralysis with laryngeal edema, again, it may increase the respiratory obstruction. We have tracheal problem, laryngeal edema, tension hematoma, trauma, either endotracheal tube or by surgeon, nerve paralysis. All these combine to produce a respiratory obstruction. Immediately release the tension hematoma. This is emergency decompression. Intubate, if necessary, give steroids. Tracheostomy, depending upon the individual condition, we will give tracheostomy. Injury to recurrent laryngeal nerve. This is less than 1% in experienced and high volume centers. In fact, this is the commonest problem, recurrent laryngeal nerve injury. So to minimize this, in West they developed nerve monitoring during surgery, but that doesn't solve the problem. In fact, it complicated more. Anyhow, you will learn more about this nerve monitoring during thyroid surgery to minimize injury to nerves. It may be unilateral or bilateral. It may be transient or it may be permanent. Clinically, voice changes and cough may occur. Superior laryngeal nerve, again, you know, it is from vagus near the jugular foramina. There is a large internal laryngeal nerve supplies the mucous membrane of the larynx below the vocal cords, and a smaller external laryngeal nerve accompanies the superior thyroid vessels and liable for injury during thyroid surgery. The proximal to superior thyroid artery. When you ligating superior thyroid artery, this nerve, small nerve, external laryngeal nerve, may likely to get injured if proper care is not taken. As we have already seen, a competent surgeon demonstrates the anatomical structures, the relationship. A non-competent surgeon who takes casually ligate their superior external laryngeal nerve. Then what happens? There is a loss of tension in vocal cords. The power and range of the voice is decreased. Projection of voice is lost. But most of these cases passes silently. Only on voice assessment you can find it. Luckily, most of them passes silent. Who use their voice professionally change in the voice, even in the absence of narrow trauma. This is a precaution or advice you give to every person who is planned for thyroid surgery. The nerve may be intact. Anatomically, there is no danger, no damage, but still voice may change. And this is most important in persons who use their voice for their living, like teachers, singers, public speakers. Voice change means everything is changed in life. Thyroid insufficiency, when we do total thyroidectomy, it is not a failure of surgery. That is taken as a standard. Parathyroid insufficiency. There is a transient hypocalcemia in up to 50% of cases. Permanent hypoparathyroidism in less than 2% of cases. These are statistics from the high volume centers when surgery is done by an experienced surgeon. What is the cause for this hypoparathyroidism or hypocalcemia? Is removal of the parathyroids. 4, one is enough. But suppose if you remove 4, or there may be vascular injury, or both may be common. Basically, this hypothyroidism present 2 to 5 days after surgery. It may be dramatic, sometimes delayed or asymptomatic. So you have this perioral numbness and tingling in a patient after undergoing a total thyroidectomy. Paresthesia of fingers and toes can occur. Ventricular arrhythmias, laryngeal spasm. Basically, this hypocalcemia is a medical emergency. Never take it very lightly. It is a medical emergency. If you don't treat it properly, you have seen ventricular arrhythmias occur, laryngeal spasm may occur, and fits, convulsions may occur, death may result. Other common complications are wound infection. Wound can be infected at any time. Hypertrophic scar. Hypertrophic scar may hypertrophic forming keloid. Stitch granuloma can occur. These are the common complications after thyroid surgery, either for a benign or a malignant condition or a toxic. Now, any questions you can type in the box. Questions? If there are no questions, we'll close down the session. Any questions? Anybody? We'll close down the session.